Welcome to the Deep Dive. You've given us a mountain of information on renal disease, and honestly, it's a topic that can feel, well, pretty overwhelming.
It really can be.
Yeah, imagine this hidden enemy sort of silently eroding one of the body's most vital systems, often unseen until it's critically late. That's renal disease.
Mm-hmm.
So today, we're diving deep into your core sources to arm you, our future clinicians, with the insights you'll need to expose this silent threat and, truly change patient trajectories.
That's such a critical point. I mean, think about it. Kidney disease is incredibly prevalent, yet often symptoms only become apparent when a patient's GFR, their glomerular filtration rate, has plummeted.
Right.
Plummeted from a healthy 80 millimin all the way down to maybe 10 millimin.
Wow, that low.
Yeah, it's a staggering loss of function before most people even realize something is fundamentally wrong. So our mission for you, our third-year medical students, is to distill this complex topic into comprehensive, actionable knowledge. Perfect not just for your exams, but, well, for those real-world clinical decisions you'll soon be making.
Absolutely. So over the next 20 to 30 minutes or so, we're going to unpack everything. We'll start with the kidney's fundamental anatomy and how we initially assess its function.
The basics.
Then we'll dive into the surprisingly widespread systemic causes of kidney injury, things like diabetes and hypertension.
Big ones.
Huge. And we'll even tackle intricate conditions such as multiple myeloma. We'll spend some crucial time on pharmacological considerations, how drugs interact with these vital organs, which is always tricky.
Definitely.
And finally, wrap it all up with the complex, often challenging management of chronic and end-stage kidney disease. You'll quickly see just how profoundly multidisciplinary nephrology truly is.
It really touches everything.
Okay, let's get started then. All right, let's unpack the blueprint of the kidney, starting with its basic architecture. So we're talking about these two bean-shaped organs, right? Nestled snugly on either side of your spine.
Yeah, kind of tucked away back there.
Exactly, and they're flanked by the body's main vascular superhighways. The aorta, bringing in the oxygenated blood, and the inferior vena cava, taking the deoxygenated blood back to the heart.
The main pipes.
The main pipes. The renal arteries branch directly off the aorta to supply each kidney, and the renal veins drain straight into the IVC.
Yeah.
And then, of course, you have the ureters, these critical tubes, ferrying urine from the kidneys down to the bladder. So how does understanding this sort of macroscopic view immediately impact how we think about urological problems?
Well, without a doubt, that macroscopic view gives us a crucial framework. What's truly fascinating, I think, is how urological problems can stem from literally any point along this intricate drainage system.
Any point.
Any point. If there's an issue, whether it's high up in the kidney itself, down the ureters within the bladder, or even the urethra, it can back up. And that backup leads to significant kidney pathology. For instance, a blockage could be a tiny kidney stone in the ureter, or, say, an enlarged prostate affecting the bladder outflow. But both can have really profound implications for kidney health. So this understanding helps us localize the problem right from the start. Where is the issue originating?
That makes perfect sense. So from that big picture, let's zoom in. Let's go microscopic. The kidney's internal structure is incredibly intricate. You've got the outer layer, the cortex, and the inner part, the medulla.
Right.
We know that most of the nephrons, those functional workhorses of the kidney, primarily reside in that outer cortex. What are the clinical ramifications of that specific anatomical detail for us?
That's a fundamentally important point for your future practice. When we perform kidney biopsies, which are absolutely crucial for diagnosing many kidney diseases, we primarily target the cortex.
Okay, the cortex.
Exactly. The medulla, in contrast, is highly vascular. It's full of blood vessels. So advancing the biopsy needle too deep into it significantly increases the risk of vascular injury and, well, bleeding.
Which you definitely want to avoid.
You definitely want to avoid that. So a good renal biopsy specimen will consist mainly of cortical tissue, specifically to capture those nephrons, with minimal vascular structures from that corticomedullary junction. You want the filtering units, not the big pipes.
Got it. And within that cortex, the glomerulus is often the central player in kidney disease, right?
Absolutely.
So for our listeners, how would you describe a normal glomerulus under the microscope? What does healthy look like? And then what are the immediate signs that tell us something is wrong?
Okay, so a normal glomerulus, when you look at it under the microscope, should show patent capillary lumens. That just means they're open and clear, ready for filtration.
Yep.
The membranes surrounding these capillaries should be thin, really delicate, and the mesangial tissue, that's the stuff providing structural support to the capillaries, it should appear well preserved with just a few scattered cells, nice and clean.
All right.
Now, contrast that with an inflamed or damaged glomerulus, and you'll see stark differences. You might see a significant infiltration of inflammatory cells, like lots of white blood cells crowding in.
Yeah.
Or proliferation of that mesangial tissue, it gets thickened. Or even overt scarring and sclerosis of the capillaries. The source emphasizes that while the glomerulus might still be visible, sometimes you see extensive inflammation outside the glomerulus too. That's a key indicator for conditions like interstitial nephritis, so damage inside or outside the filtering unit itself.
Okay. So beyond the glomerulus, we have the tubules and the interstitium. What are their main jobs, and why is it so vital to differentiate between problems starting in the glomerulus versus the vasculature, interstitium, or tubules? Does it change how we approach things?
It absolutely changes the approach. The renal tubules are essential for the fine-tuning of urine composition. They're critically involved in water conservation, maintaining the body's acid-base balance, regulating electrolyte levels,
Right.
all that detailed work.
The fine-tuning.
Exactly. So differentiating between problems in these distinct anatomical areas, glomerular, vascular, interstitial, or tubular, is paramount. Because each points to a different class of kidney disease, and crucially, a different diagnostic workup and a different therapeutic approach.
Right.
For instance, a primary tubulopathy, something like renal tubular acidosis, will present and be treated very differently compared to, say, a vasculitis affecting the renal blood vessels or a primary glomerular disease like IgA nephropathy. You need to know where the problem lies to fix it properly.
It's so easy to just think of the kidneys as filters, endlessly removing waste. But they also have these vital endocrine functions, don't they? What are those, and why are they so relevant in kidney disease?
You're absolutely right. They're much more than just filters. That's a common oversimplification. Beyond waste excretion, the kidneys serve as critical endocrine organs.
Okay.
They activate vitamin D into its active form, calcitriol, which is fundamental for calcium and phosphate metabolism throughout the body. Bone health, essentially.
Crucial for bones.
Absolutely. And perhaps most notably, they're the primary producers of erythropoietin, or EPO.
EPO, right, for red blood cells.
Exactly. This hormone is essential for red blood cell production. So its absence in end-stage kidney disease, or ESKD, directly leads to that characteristic anemia you see in these patients, which often necessitates synthetic EPO injections or, in severe cases, even blood transfusions. This direct link highlights why we see such specific complications when kidney function falters. It's not just about waste buildup.
Moving from the kidney's intricate blueprint to the immediate bedside.
Yeah.
Let's talk about that first line of assessment, urinalysis, specifically the dipstick test. It seems incredibly valuable as a rapid screening tool.
Oh, it is. Simple but powerful.
So what are the key worrying indicators on a dipstick that should immediately make us sit up and say, okay, we need to investigate this further?
The dipstick is indeed profoundly powerful, especially for rapid screening of at-risk individuals like your patients with diabetes or hypertension. We're immediately concerned by gross proteinuria. Significant protein in the urine almost always necessitates a formal, quantitative assessment of protein loss. You need to know how much.
Okay. Proteinuria is a big one.
Big one. Persistent hematuria blood in the urine that doesn't go away is another major red flag that demands a full renal workup.
Okay.
The presence of leukocytes and nitrites is highly suggestive of a urinary tract infection, a UTI.
Right, infection signs.
Exactly. While less direct, the urine pH can provide relevant clues for suspected renal stones or certain types of UTIs. And, of course, the presence of hemoglobin directly confirms hematuria. So blood, protein, infection signs, those are your main triggers.
But a dipstick only takes you so far, right? The real magic, and often the crucial diagnostic info, comes from looking at the urine sediment under the microscope.
Absolutely. Microscopy is key.
So what's the single most crucial differentiation we need to make with red blood cells under the microscope? And what does it tell us about where the bleeding is actually coming from?
Okay, this is a really high-yield point for your exams and definitely for your future practice. Differentiating between dysmorphic and isomorphic red blood cells under microscopy is absolutely critical.
Dysmorphic versus isomorphic.
Dysmorphic means abnormally shaped RBCs. They look kind of beaten up.
Right.
This indicates a kidney origin, almost always pointing to glomerular disease, damage in the filter itself. This finding often necessitates a kidney biopsy to figure out the exact cause.
So dysmorphic means likely kidney, likely glomerulus, probably needs a biopsy.
You got it. In contrast, isomorphic or normal-looking, RBCs typically suggest a lower urinary tract origin, somewhere like the bladder or ureter. And that finding would prompt a cystoscopy by a urologist to look inside the bladder.
Okay, so that directs you down a completely different path.
Completely different. This distinction guides your very next diagnostic step significantly. It prevents unnecessary biopsies or, conversely, delayed urological investigation. Other key findings under microscopy include various crystals, telltale signs of suspected kidney stones.
Like uric acid or calcium oxalate crystals.
Exactly those. And lipid cells, or aggregates, those fatty casts, are a classic, they're not exclusive, sign of nephrotic syndrome that often correlates with that bubbly urine appearance patients might describe.
Ah, the bubbly urine, huh?
Okay. And sometimes you can even directly identify infectious cells, like those seen in schistosomiasis hematuria, leading to immediate diagnosis and treatment without needing a whole lot more workup.
Got it. So once we've done the bedside and lab tests, imaging and biopsy often come into play for a deeper look. What's our absolute first-line imaging choice for kidneys? What do we reach for first?
Ultrasound. Almost universally, ultrasound is our first-line imaging modality for kidney assessment.
Why ultrasound?
Well, it's non-invasive, no radiation, readily available, and it's excellent for quickly assessing kidney size, shape, confirming the presence of both kidneys, and detecting
The
hydronephrosis.
dilation, right?
Exactly, that telltale dilation of the renal pelvis, which can be a key indicator of an obstruction. However, a significant limitation is that it's often less effective for directly visualizing kidney stones themselves, especially the smaller ones. They can hide.
Okay, so good for size, shape, hydronephrosis, but maybe not the best for stones. So when do we bring in the big guns like CT scans and X-rays, and what are the absolutely critical caveats we must remember, especially for CTs?
Right. CT scans provide much more detailed anatomical information. They're especially good for definitively identifying kidney stones, even small ones that ultrasound might miss.
Hello?
The critical caveat with CT scans, and this cannot be stressed enough, is contrast.
Ah, the contrast issue.
Yes, we absolutely must avoid intravenous contrast in patients with abnormal kidney function. Generally, that's an estimated GFR below 60 millimin, although some say even lower, maybe 45 or 30, depending on the situation.
Why is that?
Because of the very real risk of contrast-induced nephropathy, which can severely worsen their kidney function, can push them over the edge.
Okay, so check the GFR before ordering contrast CT.
Always. X-rays, specifically kidney, ureter, bladder films, can also be useful for certain types of kidney stones, particularly calcium stones, because they are radio-opaque and show up clearly on a plain film.
Gotcha. Finally, the kidney biopsy. This sounds like the definitive diagnostic tool. When is it typically indicated? And just as importantly, when is it absolutely contraindicated, even if we strongly suspect kidney disease?
A kidney biopsy is typically indicated when we suspect glomerulonephritis, or really any renal disease of unknown origin, especially if the cause can't be determined by other less invasive means. It's often the only way to get a definitive tissue diagnosis for many conditions.
But when would you absolutely not do it?
Right, there are crucial contraindications. We would generally avoid a biopsy in patients with abnormal coagulation parameters, bleeding disorders, or being on strong blood thinners due to the obvious bleeding risk.
Makes sense.
Also, in those with very small or shrunken kidneys, they're likely already scarred down, and a biopsy probably won't yield useful diagnostic information and carries risk.
Not much healthy tissue left to sample.
Exactly. Also, in cases of polycystic kidney disease, because there's a high risk of puncturing multiple cysts and causing injury or bleeding, and generally, when suspected malignancies are present, percutaneous biopsies are avoided for cancer diagnosis due to the potential for tumor seeding along the needle track.
Okay, good to know those red lines.
Yeah.
Now let's turn to how kidney disease actually presents clinically. It sounds like the symptoms can be incredibly variable, which must make it challenging to diagnose early.
They absolutely are. The presentation can vary widely. It depends on whether the condition is acute or chronic, the specific underlying pathology, and even individual patient factors like age and gender. What's particularly challenging is that kidney disease symptoms are often frustratingly nonspecific. They can mimic so many other less serious conditions.
So what key clues should we as clinicians be actively looking for during history taking? Trying to pick up those subtle hints, given how nonspecific the symptoms can be.
A meticulous history is vital. You really have to probe for past clues. Recurrent throat infections, for instance, especially strep throat in childhood, can sometimes precede certain forms of glomerulonephritis like post-streptococcal GN,
Okay.
or a history of unexplained swelling, maybe around the eyes or in the feet, particularly in childhood, might suggest a missed nephrotic or nephritic syndrome that wasn't picked up at the time.
Right.
And a family history of renal conditions is also a significant red flag, as many kidney diseases have a genetic component. Things like polycystic kidney disease or Alport syndrome, these can be the subtle breadcrumbs that lead you towards a potential kidney diagnosis.
And beyond medical history, what lifestyle or environmental factors do we need to consider? Things that could significantly put patients at risk for kidney disease.
Yeah, several modifiable and non-modifiable risk factors are important to identify. Obesity, for instance, significantly increases the risk of FSGS, focal segmental glomerulosclerosis, which is a type of kidney scarring.
Okay, obesity is a factor.
Definitely. Chronic use of NSAIDs, non-steroidal anti-inflammatory drugs, is a well-established nephrotoxin. And remember, even the safer KOX2 inhibitors, like Celebrex or Arcoxia, are not safe for kidneys in the long term, especially in patients with baseline CKD. So you need to advise patients to minimize use if possible.
Right. Minimize NSAIDs.
Recurrent UTIs, especially in children, can lead to silent damage like reflux nephropathy if not properly managed. A history of previous dialysis, certain surgical histories, especially involving the urinary tract or major vascular surgery, and even specific hobbies can be relevant.
Hobbies, like what?
Well, the source specifically highlights endurance exercise combined with dehydration and maybe analgesic use. That combination increases the risk of rhabdomyolysis, muscle breakdown, and subsequent acute kidney injury. So a thorough social and activity history can be very telling. You need to ask about these things.
Okay, so when we examine these patients, what are we looking for on physical exam that might help us differentiate the severity or maybe the type of kidney disease?
On examination, our primary aim is often to differentiate between acute and chronic illness, because that heavily impacts prognosis and the potential for reversibility.
Acute versus chronic is key.
Absolutely. Assessing hydration status is fundamental. Both volume depletion, being dehydrated, and fluid overload can dramatically affect kidney function. We look for associated rashes, which might point towards underlying autoimmune conditions like lupus or vasculitis. And a thorough abdominal exam is critical. A palpable, distended bladder might indicate outflow obstruction. Renal angle tenderness, that CDA tenderness when you tap on their back, can strongly suggest pyelonephritis, an infection, or perhaps stones causing blockage. These physical findings, though often subtle, can be powerful corroborating evidence for your suspicions.
Okay, let's shift gears now and explore those systemic links, how other common diseases directly injure the kidneys. So we've explored the kidney's intricate defenses. But what happens when other major diseases, systemic powerhouses like diabetes and hypertension, wage war on these vital organs? Let's unpack how these common conditions directly injure the kidneys, starting with diabetes. It's a massive public health challenge. How exactly does poorly controlled, long-standing diabetes lead to kidney injury?
Yeah, diabetic nephropathy is truly multifactorial, and this is a crucial insight. It's not just one thing, it's a cumulative assault from multiple directions.
Oh.
Poorly controlled, long-standing diabetes impacts the kidneys through several distinct mechanisms. First, you have hemodynamic changes, things like polyuria, dehydration. These activate the RAAS system, the renin-angiotensin-aldosterone system.
RAAS activation.
And that contributes to glomerular hyperfiltration. The kidneys basically work overtime initially. Second, there are metabolic changes, particularly the formation of advanced glycated M products, AGEs, and increased TGF-beta. These directly damage kidney cells.
Okay, direct cell damage.
Third, there's a chronic inflammatory response within the kidney. And finally, fibrotic changes occur, characterized by increased collagen deposition and VEGF factors, leading to scarring. All these processes activate these complex intracellular signaling pathways that lead to a cascade of, irreversible damage if it goes on too long.
And what's a tangible progression of that damage within the kidney itself? Like, what will we actually see under the microscope over time?
The progression typically begins with that glomerular hyperfiltration we mentioned. The kidneys try to compensate by working overtime. This then leads to glomerular hypertrophy. The glomeruli actually get bigger.
They enlarge.
Yeah, they enlarge.
Oh.
Followed by mesangial expansion, where the supporting cells within the glomerulus proliferate and the matrix expands. Eventually, this progresses to widespread glomerular sclerosis, that's scarring of the filtering units, and then to extensive kidney fibrosis and tubular interstitial fibrosis. The surrounding tissue gets scarred too.
So it's a progressive scarring process.
Exactly. And the clinical takeaway here is vital for you. tight glucose control is absolutely paramount. Not just to control blood sugar for its own sake, but specifically to prevent the activation of these damaging pathways and slow or prevent the progression of diabetic kidney disease. Even minor, persistent deviations in glucose or blood pressure contribute to significant compounding damage. It emphasizes the need for constant vigilance.
Okay, next up, hypertension, another huge contributor to kidney disease. What's the mechanism by which high blood pressure, which seems like a separate circulatory issue, actually causes such direct damage to the kidneys?
Yeah, it seems separate, but it's intimately linked. Systemic hypertension causes direct endothelial cell dysfunction and damage within the kidney's delicate microvasculature. Those tiny blood vessels get damaged.
Okay.
This leads to what we call glomerular hypertension. The pressure inside the glomerular capillaries themselves becomes chronically elevated.
So high pressure right inside the filter.
Exactly. And this sustained high pressure results in glomerular cell hypertrophy, direct tubular damage, and it fosters a chronic state of inflammation and oxidative stress within the kidney tissue itself. It's under constant strain.
And how does that relentless pressure translate into chronic kidney disease and potentially end-stage kidney failure?
Over time, these factors, the endothelial damage, the glomerular hypertension, the inflammation, the oxidative stress, they collectively drive the insidious progression of chronic kidney disease. The pathological changes you'd see include expensive glomerular sclerosis, scarring again, atherosclerosis of the renal vessels, hardening of the arteries within the kidney, widespread tubular atrophy, and severe interstitial fibrosis.
So similar scarring patterns to diabetes driven by pressure.
Very similar endpoints, yeah, driven by that hemodynamic stress. Ultimately, if it's uncontrolled, this leads to end-stage kidney failure requiring renal replacement therapy. But what's particularly striking and really relevant for us in South Africa is its high prevalence as a cause of ESRD, especially among individuals of Black African descent.
Why is that?
Well, it's partly due to APL1 gene variants, which seem to predispose certain populations to a more aggressive form of hypertensive kidney damage. It essentially makes their kidneys inherently more vulnerable to the effects of high blood pressure.
That's important context. Given that stark reality, what are the management goals for hypertension when we know it's impacting kidney function? And how do we overcome that physician inertia in actually getting patients to those targets?
Aggressive blood pressure control is paramount, absolutely paramount. While the general target for uncomplicated hypertension might be, say, 490 millimole Hg for patients with proteinuria or diabetes, the target is often stricter, usually around 80 millimole Hg.
Okay. Lower target for kidney patients.
Generally, yes. The landmark SPRINT trial even suggested a systolic target of 120 millimole Hg for certain high-risk groups, although that's still debated a bit. We emphasize using primary drugs like ACE inhibitors or ARBs. They have specific kidney protective effects, especially with proteinuria. Then calcium channel blockers, diuretics, alpha blockers, whatever it takes.
Right.
But crucially, we need to overcome physician inertia. That common challenge where clinicians, maybe due to time pressures, concerns about polypharmacy, fear of side effects, whatever, they just don't intensify treatment enough to reach the target blood pressure.
They settle for good enough instead of target.
Kind of, yeah. And adherence is also a massive factor. Patients might stop their medication due to side effects, cost, complexity. So you, as clinicians, need to actively ask about adherence and any experienced adverse effects. You have to work with the patient to get them to goal.
Makes sense. Okay, let's talk about HIV-associated nephropathy, or HIVAN. What exactly is it, and what's its most common manifestation clinically?
So HIVAN refers to kidney disease that develops in direct association with HIV infection itself. The most common cause, accounting for a significant 80–90% of cases, is a specific type of kidney injury called collapsing focal segmental glomerulosclerosis, or collapsing FSGS.
Collapsing FSGS.
Yeah. And this is particularly seen in individuals with low CD4 counts and advanced, uncontrolled HIV disease. Clinically, HIVAN typically presents as nephrotic syndrome, heavy proteinuria, low albumin, swelling, and it often progresses rapidly, sometimes within just a few months, to end-stage kidney disease if it's left untreated.
Wow. That's fast. How does HIV actually cause this kind of kidney damage at a cellular level? It's not just a systemic viral effect, is it? It targets the kidney specifically.
Precisely. The pathophysiology is quite intricate. It's not just general inflammation from the virus. It's thought to be caused by direct infection of kidney cells, specifically the podocytes, those crucial cells in the filter, and the tubular epithelial cells by the HIV virus itself.
The virus gets inside the kidney cells.
Yes. And subsequent kidney damage is mediated by viral gene products, the proteins the virus makes, and a cascade of cytokine release during the infection. That APOL1 gene we mentioned earlier with hypertension, it's expressed in the kidney and is also a significant predisposing factor for HIV in certain populations. It links back again. Additionally, you can get immune complex deposition in the glomerular basement membrane and a distinct tubular interstitial inflammation contributing to the damage. There's also an association between HIV and thrombotic microangiopathy, a microvascular clotting disorder which can further lead to acute kidney injury. So multiple hits possible.
Can you walk us through a classic case example from your sources? Something to illustrate HIV and its management, especially highlighting that crucial link to HIV treatment itself.
Certainly. Your source describes a very illustrative case. A 28-year-old HIV-positive patient. He presented with generalized body swelling, a classic sign of fluid overload.
Anasarca.
Exactly. Widespread anasarca, indicating severe fluid retention. And he had features of advanced, uncontrolled HIV. His urine dipstick showed 4+ proteinuria, massive protein leak. Lab findings confirmed low albumin and high cholesterol, classic hallmarks of nephrotic syndrome. Critically, lab tests also revealed a very low CD4 count and a high viral load, confirming his HIV was uncontrolled. An ultrasound showed large swollen kidneys, which is a common finding in HEDAN.
Right.
So after a kidney biopsy confirmed the diagnosis of HAN, the patient was successfully treated primarily with HIV medication, antiretroviral.
So not with traditional immunosuppressants.
Generally not for HIV. His nephrotic syndrome resolved, and his kidney function improved significantly just with the HIV treatment. This case powerfully highlights that for HAN, the primary immunosuppression is often simply effective HIV treatment. Controlling the virus controls the kidney disease. Traditional immunosuppressants are usually not indicated and can be harmful.
That's a really critical point. Treat the HIV first. Okay, let's talk about blockages now. Obstructive uropathy. This can be a significant and often reversible cause of kidney injury. Before we dive deeper, can you clarify the precise distinctions between obstructive uropathy, obstructive nephropathy, and hydronephrosis? These terms sound similar and can be confusing.
They often are used interchangeably, but yeah, the distinctions are important for precision. Obstructive uropathy is the broadest term. It simply refers to any blockage of urinary flow affecting one or both kidneys. It just describes the anatomical presence of an impediment.
Okay, uropathy is just the blockage.
Right. Obstructive nephropathy, in contrast, is a more severe situation. It means the obstruction has been present long enough or is severe enough to actually affect kidney function, leading to measurable kidney damage. So, obstruction causing nephron damage.
Got it. Obstruction plus damage.
Exactly. And hydronephrosis describes the physical dilation or swelling of the renal pelvis, that funnel-like structure in the kidney that collects urine. Importantly, hydronephrosis can be present with or without an actual obstruction. Sometimes it's just an anatomical variation and not causing a functional issue, though it's often a key sign of an underlying blockage.
Okay, so hydro is the swelling, which might or might not be from a significant blockage. What are the most common culprits behind this urinary flow obstruction, and are there any less common ones we should also keep in mind?
Yeah, the common causes we encounter frequently include renal stones, nephrolithiasis. Benign prostatic hypertrophy, or BPH, in older males is very common, prostate cancer, and bladder tumors. Those are the big four, probably.
Stones, BPH, prostate cancer, bladder tumors.
Right. Less commonly, we see things like ureteropelvic junction obstruction, where the ureter meets the kidney is narrowed congenitally, cystocele, which is bladder prolapse, often in women, bladder herniation, iatrogenic injuries that occur after pelvic surgery, unfortunately, or broader pelvic malignancies pressing on the ureters. The cause can also be unilateral, like an acute stone jamming one ureter or an injury affecting one side, or bilateral, which might suggest something lower down affecting both kidneys, like BPH or maybe a bladder neck issue.
From an epidemiological perspective, who is most at risk for developing, say, renal stones or BPH? Are there certain demographics or environmental factors that play a role?
Absolutely. For renal stones, they're thought to be more common in hot and dry climates, likely due to chronic dehydration.
Makes sense.
Obesity significantly increases the incidence. They're typically seen in individuals aged maybe 30 to 50, and there's a definite male predisposition, often 2 to 3 times more common in men.
Okay, men 30, 50 in hot climates may be overweight. What about BPH?
For prostate-related causes, BPH prevalence increases significantly with age, really starting from the 5th decade onwards. And it's notably more common in certain ethnicities, such as Black patients. Age and ethnicity are big factors there.
So how does this physical obstruction actually damage the kidney at a physiological level? What's the cascade of events that leads from a simple blockage to actual kidney injury?
The pathophysiology is quite logical once you think about the plumbing. An obstruction immediately leads to an increase in hydrostatic pressure within the collecting ducts. It's like kinking a hose, you get back pressure.
Right, back pressure.
Yeah.
Painful.
Painful, exactly. This elevated pressure then causes a decrease in renal blood flow, which in turn reduces the glomerular filtration rate, the GFR. The kidney tries to compensate by upregulating the renin-angiotensin-aldosterone system, but this prolonged pressure and reduced blood flow ultimately lead to atrophy and apoptosis programmed cell death of the renal tubules, and that contributes to interstitial fibrosis, scarring.
So the pressure kills the tubules and causes scarring.
In essence, yes. If left untreated, this progressive damage results in decreased reabsorption of solutes in water, an inability to concentrate urine, and impaired excretion of hydrogen and potassium, leading to acidosis and hyperkalemia. This unchecked process leads to irreversible renal damage. A crucial clinical pearl here: if only one kidney is affected by an obstruction, the urine output and serum creatinine may remain completely normal because the other kidney compensates brilliantly.
So normal labs don't rule it out if it's unilateral.
Exactly. You need a high index of suspicion based on symptoms like pain. However, complete anuria, absolutely no urine output, should strongly suggest bilateral obstruction or obstruction in a patient with only one functioning kidney. That's an emergency.
What are the absolute key diagnostic symptoms that should immediately make us suspect obstructive uropathy in a patient? What should we be listening for?
Okay, key diagnostic factors are oliguria, low urine output, or anuria, no urine output, though remember, output can be misleading in unilateral cases. Renal colic, that severe colicky flank pain, often radiating down towards the groin, is very typical. Patients often describe it as the worst pain of their life.
Unforgettable pain.
Yeah. Infective symptoms like fever, dysuria, painful urination, or urinary frequency often accompany obstruction, signaling a UTI complicating the blockage. A distended abdomen, which might be a palpable bladder if the obstruction is low down, and hematuria, blood in urine, are also important signs. In more chronic, slowly developing cases, patients might report less acute symptoms like chronic urinary frequency, getting up at night, nocturia, maybe some weight loss, or changes in bowel habits, which could hint at an underlying malignancy causing the obstruction.
What laboratory investigations should we prioritize when we suspect an obstruction? And what specific findings are we looking for in each test?
We always start with the basics: a urine dipstick and a formal urinalysis with microscopy. We're looking for leukocytes and nitrites, strongly suggesting infection. The urine pH can be relevant for certain stone types or UTIs. Hemoglobin confirms hematuria.
Okay, urine first, then blood.
Then bloods, yes. Renal electrolytes, including urea and creatinine, to assess the extent of renal damage, or AKI. A full electrolyte panel, including calcium, bicarbonate, phosphate, and uric acid, is important, especially if kidney stones are suspected, as these can be components of stones or indicate underlying metabolic issues. A full blood count assesses for anemia or signs of infection or inflammation. And crucially, for suspected prostate-related obstruction in men, tumor markers like PSA for prostate cancer might be indicated.
Speaking of prostate issues, prostate-specific antigen, or PSA. It's a critical biomarker for prostate cancer, but it sounds like it has significant limitations, doesn't it? It's not as straightforward as just getting a number.
It absolutely does have limitations. This is a common point of misunderstanding, even among clinicians sometimes. PSA is indeed prostate-specific, meaning it generally comes from the prostate gland, but it is not cancer-specific.
Not cancer-specific.
Okay, this means elevated levels can be caused by many benign conditions, like BPH itself, urinary tract infections, prostatitis, certain drugs affecting androgen levels, or even physical prostate manipulation during a digital rectal exam, DRE, or recent biopsy. This non-specificity creates a significant risk of overdiagnosis and overtreatment, potentially exposing patients to unnecessary anxiety, biopsies, and interventions with side effects.
So who should be screened with PSA, and what are the real challenges in interpreting these results for actual diagnosis? It sounds like there's a lot of nuance involved.
Screening guidelines remain pretty controversial, and practice varies quite a bit. Generally, the highest potential value for screening is seen in males over 50, or perhaps starting between 40 and 50 if there's a strong family history of prostate cancer, maybe screening every 2 years or so.
Oh.
For diagnosis, there's no single PSA level that conclusively rules cancer in or out. Around 15% of patients with a supposedly normal PSA, less than 4 ngml, can still harbor prostate cancer. The so-called gray zone between 4 and 10 ngml often warrants further testing, like checking the free PSA percentage or PSA velocity before jumping to a biopsy. Crucially, PSA alone is never diagnostic. An elevated PSA coupled with an abnormal digital rectal exam, like feeling a nodule, should definitely prompt a biopsy for definitive diagnosis. You can't just rely on the number. Clinical context is everything.
And how is KSA effectively used for monitoring, perhaps after treatment? Are there any advanced techniques that help refine its utility?
Yeah, for monitoring, it's much more useful, especially after definitive treatment like prostatectomy or radiation. Undetectable PSA levels are the ideal goal. It's vital to use the same assay type for consistent monitoring over time, as PSA levels are sensitive to even small increments, allowing for early detection of recurrent or residual disease. Advanced techniques include measuring the free PSA percentage. A lower percentage suggests higher cancer risk. PSA velocity, how quickly it's rising over time. PSA doubling time, a shorter doubling time is more concerning for malignancy. And PSA density, which relates the PSA concentration to the prostate volume measured on ultrasound. These advanced measures help in risk stratification and guide further management decisions, especially in that gray zone or for monitoring after treatment.
Let's transition to a different form of obstruction, renal calculi or kidney stones. We know they're common, but how exactly do these crystalline structures actually form in the urinary system? What's the underlying pathogenesis?
Kidney stones are essentially crystalline formations within the urinary system. They're a mix of crystalloid material and an organic matrix. Their pathogenesis involves a complex interplay of factors. Basically, you need an increased concentration of urinary solutes, things like calcium, uric acid, oxalate, sodium.
Too much stuff dissolved in the urine.
Exactly. Combined with decreased levels of natural stone inhibitors, substances the body produces to prevent stones, like citrate and magnesium. When these conditions align with a low urinary volume, often due to dehydration and maybe an abnormally low or high urinary pH, it results in urine supersaturation. And that's when stone formation begins. It's like too much sugar dissolving in a glass of iced tea eventually. If you add too much or the tea cools down, it starts to crystallize out.
Got it. Supersaturation leads to crystals. How are these stones classified by their chemical composition, and what are the key clinical implications or associated conditions for each type? Does knowing the type matter?
Oh, knowing the type matters hugely because it guides prevention and treatment. The classification by composition is crucial. The most common are calcium stones, making up about 80% of all stones.
80%.
Okay. Yeah, the vast majority. These are primarily calcium oxalate, with some being calcium phosphate or hydroxyapatite. Calcium phosphate stones are sometimes linked to conditions like hyperparathyroidism or renal tubular acidosis. Then we have uric acid stones, about 10% of cases. These are strongly associated with acidic urine, a pH below 5.5, and high levels of uric acid in the urine. Hyperuricosuriasia, often seen in patients with gout or those eating diets very high in purines like red meat and shellfish.
Okay, calcium and uric acid are the main ones. What else?
Sustained stones are rare, maybe 1–2%, but highly significant because they relate to cystinuria, an inherited metabolic disorder affecting amino acid reabsorption in the tubules. These often start in childhood and can be difficult to treat. Finally, struvite stones, making up maybe 1–5%, are often called infection stones.
Infection stones.
Yeah, because they're typically composed of magnesium, ammonium, and phosphate, and they characteristically form these large, branching staghorn calculi that can fill the whole collecting system. They're caused by urea-splitting bacteria, like Proteus, Pseudomonas, and Klebsiella, which raise the urine pH and allow these minerals to precipitate.
Wow, staghorn calculi. That sounds serious.
Mm.
How do patients with kidney stones typically present? What are the classic symptoms we should be listening for?
The presentation varies wildly. Some stones are completely asymptomatic and are just found, incidentally, on an imaging scan done for another reason.
Silent stones.
Silent stones, yeah. At the other end of the spectrum, you have that excruciatingly severe colicky flank pain we talked about, renal colic. This pain can radiate down to the lower abdomen, groin, or even the genitals as the stone moves. Patients might also present with symptoms related to the underlying cause, like if they have hypercalcemia, they might have the classic bones, stones, abdominal moans, and psychic groans. Or they might present with complications, like a urinary tract infection on top of the stone, manifesting as fever and dysuria, or even acute renal impairment if the stone causes significant obstruction. Hematuria, either visible blood, macroscopic, or microscopic blood found on urinalysis, is also a very common finding.
And what are the key risk factors and investigations for diagnosing renal calculi? What's the take-home message here for students trying to remember this?
Risk factors are diverse. High protein and high salt intake are big dietary ones. Ethnicity plays a role. There seems to be a predisposition in white populations. Male gender. Chronic dehydration, maybe from living in a hot climate or having a certain occupation. Obesity is a risk factor. And a strong family history is important. Certain medications, like calcium antacids, topiramate, or high doses of vitamins C and D, can also precipitate stones.
Yeah, and investigations.
Investigations often involve looking for low urine volume via a 24-hour urine collection. We check for hypercalciuria, high urine calcium, and if that's found, we assess PTH and vitamin D levels to look for underlying causes. We also check for hyperoxaluria, high oxalate, hypocitraturia, low citrate, the inhibitor, or hyperuricasuria, high uric acid. Stone analysis, if a stone is passed or surgically removed, is crucial for determining its exact composition to guide future prevention. Imaging, typically with X-rays, ultrasound, and especially non-contrast CT scans, low-dose CT is often preferred now, is used for diagnosis and localization.
So what's the bottom line for students?
The critical take-home message is that multiple risk factors often coexist. Recurrent stones, especially if they start in childhood, absolutely demand a thorough metabolic investigation to find an underlying cause. And remember that calcium stones are by far the most common type, so knowing their presentation and risk factors is vital for your exams and practice.
Okay, let's pivot now to a very different beast. Multiple myeloma. This is a hematologic malignancy, a blood cancer, but it has profound and often early renal implications. Can you walk us through its journey, maybe from a benign precursor state to full-blown aggressive disease?
Certainly. Multiple myeloma lies within a spectrum of plasma cell disorders, which we call gammopathies. It often begins as something called monoclonal gammopathy of undetermined significance, or MGUS.
MGUS.
Right. MGUS is typically asymptomatic and considered a benign precursor state. It carries a small risk, maybe 1% per year, of progressing. This can then progress to a pre-malignant state called smoldering multiple myeloma, then to active multiple myeloma, and in some rare, very aggressive cases, even to plasma cell leukemia.
Wow. So what is multiple myeloma at its core?
At its core, multiple myeloma is a clonal B-cell disease. It's characterized by the uncontrolled proliferation of abnormal plasma cells, usually in the bone marrow, and these abnormal plasma cells produce huge amounts of a single type of monoclonal antibody, or antibody fragment, which we call a paraprotein, or M protein. These paraproteins are central to many of its systemic effects, especially in the kidney.
And what are the broader systemic manifestations of this uncontrolled plasma cell proliferation? It sounds like it affects much more than just the blood or bone marrow.
You're absolutely right. It's a systemic disease with widespread effects. The proliferation of these abnormal plasma cells in the bone marrow leads to extensive systemic issues. Primarily, it causes widespread skeletal destruction. You get these osteolytic lesions, punched out holes in the bone due to a severe imbalance where osteoclast activity, bone resorption, is massively increased.
So the bones get eaten away.
Essentially, yes. This leads to osteopenia, weakened bones, and a very high risk of pathological fractures, bones breaking with minimal or no trauma. This bone pain or fracture can often be the initial presenting symptom that brings the patient in.
Okay.
The sheer infiltration of the bone marrow also crowds out normal blood cell production. So patients often develop unexplained anemia, and they become significantly more susceptible to recurrent infections because their normal antibody production is suppressed. It's typically a disease of older individuals with a median age around 65 years.
So how does active multiple myeloma typically present clinically? We often hear about the CKD criteria as a mnemonic for the key features. Can you break those down for us, especially highlighting the renal component?
Yes, the CKD criteria are absolutely classic for the clinical presentation and are crucial for diagnosis. CKD stands for C, hypercalcemia. Elevated calcium levels in the blood primarily due to that extensive bone destruction releasing calcium.
Okay, high calcium.
Our renal insufficiency, this is our primary focus here. It's formally defined as a creatinine clearance less than 40 LMN or a serum creatinine greater than 177 micromole, which is 2 milligdl. Kidney damage is very, very common in myeloma.
Got it. R is for renal.
A, anemia. Typically normocytic, normochromic anemia with hemoglobin more than 2 GDL below the lower limit of normal or just less than 10 GDL. This is secondary to the bone marrow infiltration crowding out red cell production. Patients often complain of profound fatigue.
Okay, anemia.
B, bone lesions. One or more osteolytic lesions detected on skeletal survey, like X-rays, although more sensitive imaging, like low-dose whole-body CT or PET-CT scans, are now preferred for detecting these bone lesions. This causes symptoms like persistent back pain, bone pain, and those pathological fractures.
CRAB, calcium, renal, anemia, bone. Got it. Are there other symptoms?
Yes. Beyond SCRAB, patients may also experience constitutional symptoms like unexplained weight loss or fevers, sometimes organomegaly, enlarged liver or spleen, hypogammaglobulinemia, low levels of normal antibodies leading to infection risk, hyperviscosity syndrome, thick blood causing neurological symptoms or visual changes, amyloidosis, paraprotein deposition in organs, and that increased susceptibility to recurrent infections due to immune deficiency.
Let's really hone in now on the kidney failure aspect. It sounds particularly complex and multifactorial in multiple myeloma. What are the main immunoglobulin or light chain-mediated mechanisms that cause kidney damage in these patients? How do those abnormal proteins hurt the kidneys?
This is a critical area for understanding, and you're right, it's all driven by the overproduction of those monoclonal immunoglobulins, or, more often, just their fragments, the free light chains. There are several ways they cause damage. 1. Monoclonal immunoglobulin deposition disease, MIDD. These abnormal proteins can deposit directly into various kidney structures, the glomerular basement membranes, the tubular basement membranes. They can deposit as intact light chains, LCDD, heavy chains, HCDD, or both, LHCDD, or sometimes as unmodified whole immunoglobulin, amyloid fibrils, or cryoglobulins. Each pattern causes distinct histological damage.
So they just kind of clog up the structures.
They deposit and disrupt the normal architecture, yeah. 2. Amyloidosis. This is a specific and often severe form of deposition where the monoclonal light chains misfold and form insoluble amyloid fibrils. These fibrils then deposit in the glomeruli and other organs, causing significant and progressive organ damage. AL amyloidosis is a serious complication of plasma cell disorders. 3. Myeloma cast nephropathy, or light chain cast nephropathy. This is the most common cause of acute kidney injury, AKI, in multiple myeloma. What happens is you get extremely high levels of free light chains, either kappa or lambda, in the filtrate. These overwhelm the proximal tubule's ability to reabsorb them. They then travel down to the distal tubules and combine with a protein normally found in urine called TAM horsefall protein. Together they form these large, dense, waxy casts that physically block the tubules.
They literally plug up the kidney's plumbing.
Exactly, like sludge in the pipes. This leads to obstructive AKI. 4. Fanconi syndrome, proximal tubulopathy. This represents a generalized dysfunction of the proximal tubules. It's not just one transporter affected, it's a widespread failure of reabsorption. This leads to impaired reabsorption of essential substances like amino acids, phosphate, glucose, bicarbonate, uric acid. They all just spill into the urine.
So you lose everything in the urine.
You lose a lot of important stuff, yeah. Resulting in things like aminoaciduria, phosphaturia, glycosuria, hyperuricemia, and corresponding low serum levels like hypophosphatemia, hypokalemia, and a characteristic proximal renal tubular acidosis. It can be caused by light chain crystal deposition within the tubular cells, or sometimes tubular obstruction by casts. 5. Direct glomerular damage. Beyond deposition diseases, other specific forms of glomerular damage can occur, like proliferative glomerulonephritis with monoclonal immunoglobulin deposition, PG and MID, cryoglobulonemic glomerulonephritis, or fibrillary glomerulonephritis. These are rarer but important causes of glomerular injury in MM.
Okay, so those are the direct immunoglobulin-mediated effects, which sound quite diverse and damaging. But are there significant non-immunoglobulin-mediated causes of kidney failure in multiple myeloma that we should also be aware of? Things not directly caused by the paraprotein.
Yes, absolutely. And the most significant non-immunoglobulin-mediated cause is hypercalcemia.
Back to the C in SRAB.
Exactly. Due to that extensive bone destruction and osteoclast activation in myeloma, large amounts of calcium are released into the blood. This high filtered load of calcium can then precipitate and form crystals within the kidney tubules themselves, leading to acute kidney injury. If it's left untreated, that AKI can progress to chronic kidney disease.
Okay.
Hypercalcemia can also directly contribute to Fanconi syndrome, and it causes significant polyuria, excessive urination, and volume depletion, sometimes presenting as nephrogenic diabetes insipidus, where the kidneys can't respond to ADH. Furthermore, high calcium can cause renal vessel constriction, contributing to prerenal impairment, and it even promotes the formation of those light chain casts, worsening myeloma cast nephropathy. So, hypercalcemia is bad for the kidneys in multiple ways, independent of the light chains themselves. Other factors like dehydration, use of NSAIDs, or contrast dye exposure can also precipitate AKI in myeloma patients who are already vulnerable.
How do we actually diagnose multiple myeloma, especially keeping these potential renal implications in mind? What are the key diagnostic criteria and the initial laboratory investigations we should be ordering right off the bat?
The International Myeloma Working Group, or IMWG 2014 guidelines, are the gold standard we use for diagnosis. To diagnose active symptomatic multiple myeloma, you need two main things. One, evidence of the clonal plasma cells, either bone marrow plasma cells making up 10% of the cells on biopsy, or a biopsy-proven plasmacytoma, a solid tumor of plasma cells.
Okay, proof of the abnormal cells.
Right. And number two, play-LS at least one myeloma-defining event, MDE, that is clearly attributed to that plasma cell proliferation. These MDEs include the CIRAB criteria we just discussed, hypercalcemia, renal insufficiency using those specific cutoffs, CRCL40 or creatinine in 177, anemia, HB10 or 2-GDL below normal, and bone lesions, one or more on imaging.
The clonal cells plus CR equals myeloma.
Essentially, yes. But there are also additional biomarkers of malignancy that now also count as MDEs, even without classic CIRAB symptoms. These include very high bone marrow plasma cell percentage, 60%, a markedly abnormal serum-free light chain ratio, Dune-involved ratio 100, or more than one focal lesion seen on MRI. These indicate a very high risk of progression to symptomatic disease soon, so they trigger treatment.
Okay, what about the initial lab workup? What should we order?
For initial lab workup, you need to cast a wide net, thinking about all the potential complications. Urea, creatinine, and electrolytes. Absolutely essential to assess kidney function, looking for AKI or CKD. Identify electrolyte abnormalities like potassium bicarb. And check for acid-base disorders like metabolic acidosis, which you might see in Fanconi syndrome. Full blood count. To evaluate for anemia, type and severity, and check for any other cytopenias, low white cells or platelets. Calcium, magnesium, and phosphate, specifically checking for hypercalcemia, presence and degree, and hypophosphatemia, which is a key feature of Fanconi syndrome. Liver function tests, particularly looking at total protein and albumin. High total protein with normal or low albumin gives you a high globulin gap, which strongly suggests the presence of a large amount of monoclonal protein. Hypoalbuminemia can also be seen. Immunoglobulins, quantitative levels, IgG, IgA, IgM, can show suppression of normal immunoglobulins and sometimes elevation of the myeloma type. Urine tests, absolutely critical. Need a urinalysis looking for protein. Need specific tests for proteinuria quantification, like urine protein to creatinine ratio or 24-hour urine protein. And crucially, urine testing for Bence-Jones protein, monoclonal free light chains in the urine. Plus, checking urine for glucose, phosphate, uric acid to screen for Fanconi syndrome.
And once we have these initial suspicions, maybe from the globulin gap or the CRAB features, how do we definitively confirm the presence of that crucial monoclonal protein or paraprotein, which is really the hallmark of multiple myeloma?
Right. You need to nail down that monoclonal protein. We use a combination of highly sensitive tests, serum protein electrophoresis, SPF, and this is the initial screening test. It separates serum proteins by charge and size, looking for a distinct narrow band in the gamma globulin region, that's the monoclonal band, often called an M spike.
The M spike on SPATE.
Immunofixation, IFX. This is performed on both serum and urine. It's more sensitive than electrophoresis and is used to confirm the presence of a monoclonal protein if the CEP is suspicious or even normal. And critically, it identifies the specific type of M protein, for example, IgG kappa, IgA lambda, or just free kappa or lambda light chains. Urine protein electrophoresis, UPEC, urine immunofixation, UIFE, specifically looks for monoclonal proteins, especially free light chains, Bence-Jones protein, in the urine. Sometimes light chains are excreted heavily in urine, even if the serum M spike is small or absent. Serum-free light chains, SFLC assay. This is a very important quantitative blood test. It measures the levels of unbound kappa and lambda light chains and calculates their ratio. A highly abnormal ratio, example, involved chain to uninvolved chain ratio 100, is a myeloma-defining event indicating a very aggressive clonal proliferation. Serum-free light chains, SFLC assay. It's also really crucial to differentiate active which needs treatment, from MGUS or smoldering myeloma. These are precursor conditions where there's a monoclonal protein but no end organ damage, no SRAB or other MDEs. Specific criteria based on the size of the M spike, or G, 30 GL for MGUS, the percentage of plasma cells in the bone marrow, 10% for MTUS, and the SFLC ratio help make this distinction. You don't want to overtreat a benign or low-risk precursor condition.
Right, staging the risk is key. Beyond these protein labs, what other diagnostic tests are important, and how is multiple myeloma actually staged to guide treatment and prognosis?
Yes, a bone marrow aspirate and biopsy are essential, not just for diagnosis, 10% clonal plasma cells usually required, but also for prognosis. Flow cytometry and immunohistochemistry on the marrow sample confirm the clonality, kappa or lambda restriction. Critically, cytogenetics, FIS, fluorescence in situ hybridization, and other chromosomal abnormality testing on the plasma cells provide vital prognostic information.
Yeah.
Certain abnormalities like deletion 17p or translocation T414 are linked to a worse prognosis and may influence treatment choices.
Okay, genetics matter for prognosis. How about staging?
For staging overall prognosis, the International Staging System, or ISS, is widely used. It classifies into 3 stages, stage 1, 2, 3, based purely on 2 blood tests, beta-2 microglobulin and serum albumin levels. Stage 3, characterized by high beta-2 microglobulin, 5.5 milligel, and potentially hypoalbuminemia, carries the worst prognosis. There's also a revised ISS, RISS, that incorporates high-risk cytogenetics and LDH levels for even better prognostic stratification.
So in summary, how does multiple myeloma manifest in the kidneys, encompassing all those complex mechanisms we discussed? And what's the ultimate take-home message for us as future clinicians when we encounter a patient with suspected and kidney problems?
The kidney manifestations of multiple myeloma are really diverse. They often present as acute kidney injury, most commonly due to myeloma nephropathy, but also potentially from acute tubular necrosis, often related to hypercalcemia or volume depletion, or acute interstitial nephritis. Patients can also present with significant proteinuria, sometimes in the nephrotic range, resulting from MID, like light chain deposition disease, or AL amyloidosis. Ultimately, any of these acute or subacute injuries can progress to irreversible chronic kidney disease if not addressed promptly. And let's not forget Fanconi syndrome, that generalized proximal tubulopathy causing significant electrolyte and acid-base disturbances.
So the take-home.
The key take-home message is that kidney impairment is a common, often multifactorial, and frequently severe complication of multiple myeloma. Early identification through vigilant screening for those CRAB criteria, especially the R for renal, and prompt investigation for a monoclonal protein if suspicion is high are absolutely paramount. Initiating effective myeloma treatment quickly is critical to prevent severe, irreversible kidney damage and progression to end-stage kidney disease requiring dialysis. Your early suspicion and workup can literally save a kidney and potentially a life in these patients. Don't ignore unexplained kidney dysfunction, especially in older adults with anemia or bone pain.
Okay, great summary. Let's transition now from specific diseases to the broader science of how drugs interact with the kidneys. This area, pharmacokinetics and pharmacodynamics in renal disease, is absolutely critical for patient safety and ensuring drug efficacy. Let's revisit pharmacokinetics, starting with the basic plasma drug concentration time curve. What does that graph really tell us at a glance?
Yeah, this curve is truly fundamental. It's like the biography of a drug dose in the body. It's a visual representation of how a drug's concentration in the plasma changes over time after it's administered. Key parameters we extract from it include the onset of action, when the drug concentration reaches a level to start working, the peak effect, represented by Cmax, which is the maximum concentration achieved, and Tmax, the time it takes to reach that peak.
Right.
Crucially, we also identify the therapeutic window, or therapeutic range. This is the concentration range between the minimum effective concentration, MEC, needed for the drug to work, and the minimum toxic concentration, MTC, above which side effects become likely. Our constant goal as clinicians adjusting doses is to maintain drug levels within the safe and effective window for as long as needed.
A crucial distinction in pharmacokinetics, especially for dosing adjustments, is between first-order and zero-order elimination. Can you clarify that for us and why it's so important clinically?
Absolutely. This distinction is vital for predicting how a drug behaves, especially when doses change or organs aren't working well. Most drugs, probably 99% of them, undergo first-order elimination. What this means is that the rate of drug elimination is directly proportional to the drug's concentration.
So the higher the concentration, the faster it's eliminated.
Exactly. Think of it as a constant fraction or percentage of the drug being eliminated per unit of time. This means the drug has a constant half-life, making its elimination predictable and dose adjustments relatively straightforward. Double the dose, you roughly double the concentration.
Okay, predictable. What about zero order?
Zero-order elimination is much less common, but important to recognize. It's seen with drugs like phenytoin, high doses of aspirin, and ethanol, alcohol. In this case, the rate of elimination is constant, meaning a fixed amount of drug, for ERG milligrams per hour, is eliminated per unit of time, regardless of the concentration.
Regardless of how much is there.
Right. It's because the elimination mechanism, usually an enzyme, is saturated. It's working at its maximum capacity. This is clinically important because their half-lives are not constant. They get longer as the concentration increases. This makes their kinetics unpredictable. And small increases in dose can lead to disproportionately large increases in concentration and a much higher risk of toxicity. It's like a checkout counter with only one cashier. It doesn't matter how long the queue gets. They can only process people at a fixed rate.
Got it. Zero order is saturated and dangerous. And speaking of half-life, what precisely determines it, and how do the kidneys play such a pivotal role in this for so many drugs?
Half-life TS is formally defined as the time it takes for the plasma drug concentration to decrease by 50%. It critically depends on two main pharmacokinetic parameters: the drug's volume of distribution, VD, and its clearance, CL. The formula is approximately Tia half Gwia 0.693 VDCL. Clearance represents the volume of plasma cleared of the drug per unit time, and it's heavily influenced by the function of eliminating organs, primarily the liver and the kidneys. The kidneys contribute to clearance through three primary processes: glomerular filtration, passive tubular reabsorption, and active tubular secretion.
Okay.
So if kidney function is impaired, any or all of these processes can be compromised. This leads to a drop in renal clearance, which directly decreases overall drug clearance. According to that formula, lower clearance means an increased half-life, and a longer half-life means a much higher risk of drug accumulation and toxicity if the dosing isn't adjusted. The kidney is truly the body's main sewage treatment plant for many water-soluble drugs and metabolites.
Let's break down these renal clearance processes one by one, starting with glomerular filtration. How does it work, and what specific characteristics make certain drugs primarily filtered here?
Glomerular filtration is essentially a bulk flow, passive process. It's driven by the hydrostatic pressure difference across the glomerular capillaries' blood pressure, pushing fluid and small solutes out of the blood and into Bowman's capsule, the start of the nephron.
Like water through a coffee filter.
Exactly like that. This process primarily filters drugs that are relatively small, usually with a molecular weight less than about 5,000 Daltons, so they can pass through the filtration slits. Critically, only the free or unbound drug fraction in the plasma is filtered. Drugs bound to plasma proteins like albumin are too large to pass through the filter easily.
So protein binding matters a lot here.
Hugely. Water-soluble hydrophilic drugs are also efficiently filtered. Good examples are aminoglycoside antibiotics like gentamicin or vancomycin or lithium. Drugs with a low volume of distribution, meaning they tend to stay within the bloodstream rather than distributing widely into tissues, also tend to be efficiently filtered because more of the drug is presented to the kidney. The glomerular filtration rate, or GFR, represents the volume of plasma filtered per unit time, and as we know, creatinine, a waste product, is freely filtered and serves as our key clinical biomarker to estimate GFR. If GFR declines, creatinine levels in the blood rise, signaling impaired filtration capacity.
Okay. Next, active tubular secretion. How is this fundamentally different from filtration? What's unique about the mechanisms involved here? It sounds more targeted.
It is much more targeted and fundamentally different. Active tubular secretion predominantly occurs in the proximal tubules, and it's a completely different process from filtration. Unlike filtration, which is passive, secretion involves active transport. It uses specific carrier proteins or transporters embedded in the tubular cell membranes.
Okay, transporters are involved.
Yes. And critically, it's an active process, meaning it requires energy, usually ATP, to move drugs against their concentration gradient, pulling them from the blood surrounding the tubules into the tubular lumen fluid. This process can significantly increase the drug concentration in the filtrate, often far beyond what filtration alone could achieve, leading to very efficient elimination for certain drugs.
Are these transporters specific?
There are several families, but two main, relatively non-selective systems handle many drugs. An anion secretion system, organic anion transporters or OATs, for weak acids, like penicillin, furosemide, salicylates, methotrexate, probenecid, uric acid. And a cation secretion system, organic cation transporters or OCTs, for weak bases, such as metformin, cimetidine, procanamide, atropine, morphine, quinine. Because they are carrier-mediated, these systems can become saturated at high drug concentrations and are subject to competition between drugs that use the same transporter.
Ah, competition. So can we actually use this active secretion process and the competition for it to our therapeutic advantage,
Yeah.
perhaps to prolong a drug's effect, or are there potential disadvantages we need to consider?
Absolutely. It can be both an advantage and a disadvantage. And understanding this competition is key to anticipating certain drug interactions. A classic therapeutic advantage was seen historically with probenecid. Probenecid strongly inhibits the OATs, blocking the renal tubular secretion of acidic drugs like penicillin.
So it stops penicillin from being pumped out.
Exactly. By competing for the same transporter, probenecid prolongs penicillin's duration of action, keeping its levels higher for longer in the bloodstream. This was genuinely used decades ago to stretch limited penicillin supplies during wartime.
Wow, clever.
It is. But competition can also be a disadvantage. Another example involving probenecid. It inhibits the secretion of nitrofurantoin, an antibiotic used for UTIs. While this might increase nitrofurantoin's serum concentration, potentially raising systemic toxicity risk, it simultaneously reduces its concentration within the urinary tract where it needs to be to fight the infection. This paradoxically makes nitrofurantoin potentially ineffective for treating UTIs when given with probenecid. So, competition for transporters can definitely cut both ways, affecting efficacy or toxicity. Metformin relies on OCTs for secretion, and drugs that inhibit OCTs, like cimetidine, can increase metformin levels and the risk of lactic acidosis.
Okay, that's really important clinically. The third process is tubular reabsorption. How does this impact drug levels after they've been filtered and potentially secreted? Is this usually something we want?
After filtration and possibly secretion add drug to the tubular fluid, drugs can then be reabsorbed from that tubular lumen back into the systemic circulation, crossing the tubular epithelium into the surrounding capillaries. This process can occur all along the renal tubules, but passive reabsorption is most significant in the distal tubules and collecting ducts.
Oh.
When drugs undergo significant reabsorption, their net excretion rate will be less than their filtration rate, GFR. Reabsorption ultimately increases the drug's half-life and reduces its overall renal clearance, which is generally an unwanted effect for drug metabolites. The body's goal is usually efficient excretion of waste products.
How does reabsorption happen,
Sure.
passively or actively?
Yeah. It can be both. Passive reabsorption is driven by concentration gradients and is most important for lipid-soluble, lipophilic, uncharged, or unionized drugs. As water gets reabsorbed along the nephron, especially distally, the concentration of these lipid-soluble drugs in the remaining tubular fluid increases, creating a gradient that drives them back across the lipid cell membranes into the blood. Ionized charged drugs, being less lipid-soluble, are poorly reabsorbed passively and are therefore trapped in the urine and readily excreted. This pH dependence of ionization is key. Active reabsorption also occurs, but it's primarily reserved for endogenous substances. The body wants to conserve things like glucose, amino acids, electrolytes, vitamins, and uric acid. These have specific transporters to pull them back from the filtrate. For instance, the SGLT2 transporters actively reabsorb glucose in the proximal tubule. And probenecid, used for gout, actually increases uric acid excretion, partly by inhibiting its active tubular reabsorption in the proximal tubule via UAT1 transporters.
This pH-dependent passive reabsorption. This leads us to a fascinating clinical application in toxicology: ion trapping. How can we actually use these principles of tubular reabsorption to deliberately accelerate the elimination of certain drugs or toxins in an overdose situation?
Ion trapping is a clever and sometimes clinically powerful strategy, especially in poisoning cases. The principle is to manipulate the urine pH, make it more acidic or more alkaline, to alter the ionization state of a weak acid or weak base drug in the tubular fluid. By doing this, we can inhibit its passive tubular reabsorption, effectively trapping the drug in its ionized, less lipid-soluble form within the tubular lumen, making it much more readily excreted in the urine.
So how do we do that?
Okay, for example, if a patient presents with an overdose of a weakly acidic drug like aspirin, salicylate, or phenobarbital, we can alkalinize the urine by giving intravenous sodium bicarbonate. Making the urine more alkaline, higher pH, causes the weak acid drug to become predominantly ionized, charged. As the ionized form is poorly reabsorbed across lipid membranes, it gets trapped in the tubular fluid and excreted much faster.
Okay, alkaline urine traps acidic drugs. What about basic drugs?
Conversely, for an overdose of a weakly basic drug like amphetamine or PCP, we could theoretically acidify the urine, maybe with ammonium chloride or ascorbic acid, though this is rarely done now due to risks. Making the urine more acidic, lower pH, protonates the weak base, making it ionized, charged. Again, the ionized form is trapped in the urine and its excretion is enhanced. Urinary alkalinization for aspirin overdose is a classic, life-saving example of therapeutic ion trapping.
That's a great clinical pull. Beyond these core processes, filtration, secretion, and reabsorption, what other factors can significantly affect the overall renal excretion of drugs? Why are they important to consider in practice?
Yeah, several other factors definitely play a crucial role in modulating renal excretion. Molecular weight. Generally, larger molecules are filtered less easily, although secretion mechanisms can sometimes handle larger molecules. Lipid solubility. Lipophilicity. As we discussed with reabsorption, this is inversely related to renal excretion. Highly lipophilic drugs tend to have a larger volume of distribution, they like tissues more than blood, and undergo more passive reabsorption, leading to decreased net renal excretion. Water-soluble drugs are generally excreted more efficiently by the kidneys. Renal blood flow. Changes in blood flow to the kidneys can significantly impact the excretion of drugs primarily cleared by glomerular filtration. Reduced blood flow, like in heart failure or shock, means less drug is delivered to the glomeruli per unit time, reducing clearance. For drugs cleared mainly by secretion, clearance can sometimes exceed renal blood flow if extraction is very high. Plasma protein binding. This is a big one. Only the unbound or free drug fraction is available for glomerular filtration and usually for active transport, secretion reabsorption. So drugs that are highly bound to plasma proteins like albumin or alpha-1 acid glycoprotein generally have lower renal clearance and often a longer half-life because only a small fraction is available for elimination at any given time. Biological factors. Age is critical. Renal clearance is significantly lower in neonates and tends to decline progressively in the elderly due to natural decline in GFR. Various disease states, not just kidney disease itself, but also conditions affecting renal perfusion like hypertension, diabetes, congestive heart failure, hemorrhage, or shock can significantly impair drug elimination. Urine flow rate and pH also play roles, as we saw with ion trapping.
So given all these complex factors, how does actual renal disease, CKD or AKI, specifically impact the overall ADME, absorption, distribution, metabolism, and excretion of drugs? What are the key changes we should anticipate as clinicians when treating these patients?
Renal disease can profoundly impact really all phases of pharmacokinetics, not just excretion. Absorption may be less intuitive, but absorption from the GI tract can sometimes be decreased in uremia. This might be due to gut edema, altered GI motility, gastroparesis is common, changes in gastric pH due to medications like phosphate binders, or even effects on first-pass metabolism in the gut wall or liver, which can sometimes be affected by uremic toxins.
Okay, absorption can change. What about distribution?
Distribution is often significantly altered. Impaired renal function frequently leads to decreased plasma protein binding, especially for acidic drugs that bind to albumin. This can happen because of lower albumin levels, hypoalbuminemia, structural changes in the albumin molecule caused by uremia, or displacement of the drug from binding sites by accumulating uremic toxins or other medications. This increases the free fraction of the drug, which is the pharmacologically active part, potentially increasing its effect or toxicity even if the total drug level seems normal. This also affects the apparent volume of distribution. Fluid overload, common in CKD, can also increase the VD for hydrophilic drugs.
Metabolism changes too, even though that's mainly the liver.
Yes, metabolism, biotransformation, can be affected too. Renal failure obviously delays the excretion of drug metabolites formed in the liver, and some of these metabolites can be active or even more toxic than the parent drug. Example, morphine metabolites, meperidine metabolite. Furthermore, uremia itself can sometimes alter the activity of certain hepatic metabolic enzymes. Some CYPs are inhibited, others induced by uremic toxins, thus changing the metabolic clearance of the parent drug. The interplay is complex.
And finally, excretion, the most obvious one.
And most critically, excretion, renal clearance, is significantly compromised, often proportionally to the decline in GFR. This leads to a prolonged elimination half-life, drug accumulation with repeated dosing, and a much higher risk of toxicity and adverse drug reactions, especially for drugs primarily excreted unchanged by the kidneys or those with active renal metabolites, and particularly for drugs with a narrow therapeutic index. This is where most of our dosage adjustments are focused.
This brings us directly to the practicalities of drug dosing and renal impairment. What's the general rule of thumb for when we need to start thinking about dosage adjustment, and what are the two main strategies we can employ?
The general rule of thumb is that dose reduction or interval extension is usually required when a patient's estimated creatinine clearance, or CRCL, often used as a surrogate for GFR for dosing, falls below about 60 millimin. Although for some drugs, adjustments might only be needed at lower levels, like 50 or 30 millimin. You always need to check specific drug recommendations.
Okay, CRCL 60 is the trigger to check. What are the strategies?
There are two main strategies for adjustment, aiming to achieve the same average steady-state concentration as in patients with normal renal function. 1. Keep the usual dose, but prolong the dosing intervals. For example, instead of giving gentamicin every 12 hours, you might give it every 24 or 48 hours, depending on the patient's CRCL and drug kinetics. This allows more time for the drug to be eliminated between doses, preventing accumulation. 2. Decrease the dose amount, but maintain the usual dosing interval. This is often done with drugs that need more constant levels, like digoxin, where you might reduce the daily maintenance dose but still give it once daily. 2. Decrease the dose amount, but maintain the usual dosing interval. Sometimes a combination of both is used. It's important to remember that the loading dose, if one is normally used, is generally unchanged in renal impairment. The loading dose depends mainly on the volume of distribution, which might be altered, but often not enough to require changing the initial dose needed to fill that volume. However, the maintenance dose or dosing interval is almost always adjusted, reduced dose or longer interval, for drugs primarily excreted by the kidneys.
And monitoring.
Oh, absolutely essential. Plasma drug concentration monitoring, therapeutic drug monitoring or TDM, must be performed whenever possible, especially for drugs with a narrow therapeutic index like gentamicin, vancomycin, digoxin, lithium phenytoin. These drugs are often contraindicated or require extreme caution and expert consultation in severe renal impairment. Exceptions to dose adjustment include drugs primarily eliminated via non-renal routes like hepatic metabolism followed by biliary excretion, for example, ceftriaxone, doxycycline, voxifloxacin, which may not need adjustment or only minor changes. To estimate CRCL for dosing, we often use equations like the Cockcroft-Gault equation, being mindful of its limitations, especially in elderly or cachectic patients, or sometimes the MDRD or CKD EPI equations, although these estimate GFR, not CRCL directly. You should be familiar with the general CRCL ranges. Normal is roughly 90-125 millilin, mild impairment maybe 60-89, moderate 30-59, severe 15-29, and kidney failure 15 LMN or on dialysis.
Okay, now on to drug-drug interactions, or DDIs. These are a potential minefield for clinicians, especially with polypharmacy. What broadly defines a DDI, and how do we distinguish between clinically relevant interactions and maybe just theoretical ones we see flagged in computer systems?
A DDI occurs when the pharmacological effect of one drug is altered by the co-administration of another drug, or by a herbal medicine, complementary medicine, or even certain foods like grapefruit juice. Polypharmacy, the use of multiple medications, significantly increases this risk, potentially leading to either subtherapeutic drug levels if one drug induces the metabolism or elimination of another, or toxicity if one drug inhibits it.
So how do we sort the serious ones from the noise?
That's the key challenge. It's crucial to distinguish between clinically significant interactions, which are supported by robust human data, case reports, clinical studies, and have a proven, measurable impact on efficacy or toxicity, leading to adverse patient outcomes, and theoretical interactions, which might be based on non-human data, like in vitro enzyme studies, animal studies, or just pharmacological plausibility, and may not always translate into clinically problematic effects for the actual patient. When prescribing, you really need to assess the quality of evidence supporting a potential interaction and the potential severity of the outcome, rather than just reacting with alarm to every single warning flag generated by electronic systems, which can lead to alert fatigue. Consider the specific drugs, the patient's condition, and the monitoring plan.
Let's delve into pharmacokinetic interactions. First, how the body affects the drug, ADME. How can interactions affect drug absorption in the GI tract?
Pharmacokinetic interactions at the absorption level are generally considered less clinically problematic than metabolism interactions, often leading to a delayed absorption or slightly reduced amount absorbed, rather than a complete failure of absorption or dangerous accumulation. They can occur if one drug alters gastric pH, like antacids, or PPIs increasing pH, which can decrease the absorption of drugs that need an acidic environment, like ketoconazole or iron supplements.
Okay, pH changes. What else?
Binding agents or adsorbents like activated charcoal used in overdoses, cholestyramine, a bile acid sequestrant, or even sucralfate or divalent trivalent cations, calcium, iron, magnesium, aluminum, and antacids or supplements, can physically bind to other drugs in the gut and prevent their absorption if taken too close together. Think tetracyclines or fluoroquinolones binding with calcium. Drugs that alter GI motility can also play a role. Anticholinergics, or opioids, slow motility and can delay absorption, while pro-motility agents might speed it up, potentially reducing absorption time for sustained release formulations.
Is there a really serious example of absorption interaction?
Yes, a critical and potentially very serious example involves malabsorption syndrome itself, sometimes drug-induced. For instance, certain drugs like orlistat, weight loss drug that inhibits fat absorption, or as mentioned in your source, maybe older drugs like para-aminosalicylic acid, PAS, used for TB, could potentially cause damage to the intestinal lining or interfere with nutrient transport, severely impairing the absorption of crucial narrow therapeutic index drugs like immunosuppressants, methotrexate, tacrolimus, or warfarin. This isn't just a minor delay, it could be a profound reduction in drug delivery leading to treatment failure, like transplant rejection. That's a major concern.
Okay, this next one is often a point of confusion. Drug interactions at the level of distribution, specifically involving competition for plasma protein binding. Can you clarify the debate around its clinical relevance? When should we truly worry about one drug kicking another off albumin?
This is indeed a widely misunderstood area, often overemphasized in older textbooks. For the vast majority of drugs that follow predictable first-order elimination kinetics, competition for plasma protein binding sites, like on albumin, is generally not clinically significant.
Really? Why not?
Well, while one drug, the precipitant, might displace another drug, the object drug, from its binding sites, temporarily increasing the free unbound concentration of the object drug, this increased free drug is then immediately available for metabolism by the liver and excretion by the kidneys. Because these elimination processes are usually not saturated, first order, the body efficiently compensates by clearing the extra free drug more rapidly. The end result is often a transient increase in free concentration, but a decrease in total concentration, with little change in the average steady-state free concentration, which drives the effect. So, in most typical scenarios, this type of interaction is a low area for clinically significant DDIs.
Okay, so usually not a big deal. But are there exceptions? When is it relevant?
Yes, there are two crucial exceptions where displacement from protein binding can be clinically relevant and potentially dangerous. One, if the displaced drug follows zero-order elimination kinetics, like phenytoin or very high doses of aspirin or warfarin, here the elimination pathways are already saturated. So when the free concentration increases due to displacement, the body cannot increase the rate of elimination to compensate. The increased free drug level persists, leading to a significant risk of toxicity.
Okay, zero-order drugs are the exception.
Right. And the second exception is, 2, if the patient has severe impairment of elimination, particularly severe renal impairment, maybe CRCL 1520 LME or severe liver failure. In this scenario, even if the drug follows first-order kinetics, the body's ability to clear the extra free drug resulting from displacement is significantly compromised. This can allow the increased free drug levels to persist and accumulate, increasing the risk of toxicity. So, unless one of these two specific conditions is met as zero-order drug or severely impaired elimination, plasma protein binding displacement interactions are typically of low clinical significance compared to interactions affecting metabolism or excretion pathways directly.
Okay, that clarifies things. So if distribution interactions are usually low yield, the most important area for pharmacokinetic DDIs is clearly metabolism, especially involving the cytochrome P450 CYP enzyme system in the liver. What are the key CYP isoforms we should be aware of, and how do enzyme inducers and inhibitors work in practice to cause problems?
Absolutely. Liver metabolism, particularly via the CYP450 system, is where the majority of clinically significant and potentially dangerous pharmacokinetic DDIs occur. The cytochrome P450 CYP family of enzymes, primarily located in the liver but also in the gut wall and other tissues, is responsible for phase-I oxidative metabolism of a vast number of drugs and endogenous compounds. Key isoforms that handle the bulk of drug metabolism include CYP3A45, the most abundant, metabolizing over 50% of currently used drugs, CYP3D6, CYP2C19, and CYP2C9. Genetic variations, polymorphisms in these enzymes also contribute to inter-individual differences in drug response.
Okay, 3A4, 2D6, 2C19, 2C9 are the big ones. What do inducers do?
Enzyme inducers are drugs or substances that increase the synthesis or activity of these metabolizing enzymes, particularly CYPs. This speeds up the metabolism of other drugs, the victim or substrate drugs, that are normally broken down by that enzyme. The result is a reduced plasma concentration and decreased pharmacological effect of the victim drug, potentially leading to treatment failure or a subtherapeutic effect.
Can you give examples?
Classic examples include rifampicin, an anti-TB drug, which is a potent inducer of multiple CYPs, including 3A4, 2C9, 2C19. If given with warfarin, metabolized by 2C9, rifampicin can drastically reduce warfarin levels, leading to insufficient anticoagulation and an increased risk of blood clots. Other common inducers include certain anticonvulsants, phenytoin, carbamazepine, phenobarbital, and St. John's wort, herbal supplement. Another example from your source, omeprazole, a PPI, can induce CYP2C19 and 2C9, potentially reducing the activation of the antiplatelet drug clopidogrel, which is a prodrug requiring activation by 2C19, increasing the risk of cardiovascular events like stent thrombosis. The source also highlights a dangerous scenario with rifampicin and the immunosuppressant cyclosporine, a 3A4 substrate. Rifampicin caused cyclosporine levels to plummet, risking transplant rejection. Then, when cyclosporine dose was increased during rifampicin therapy, stopping the rifampicin later caused cyclosporine levels to shoot up into the toxic range. Close monitoring and dose adjustments are essential when starting or stopping an inducer.
Okay, inducers lower drug levels, risk treatment failure. What about inhibitors?
Enzyme inhibitors do the opposite. They block the activity of these metabolic enzymes, often by competing for the active site or binding irreversibly. This slows down the metabolism of victim drugs normally handled by that enzyme. The result is an increase in the victim drug's plasma concentration, potentially leading to toxicity or exaggerated side effects.
Examples of inhibitors.
Many drugs are inhibitors. For example, clarithromycin, an antibiotic, is a potent inhibitor of CYP3A4. If given with a drug that has a narrow therapeutic index and is metabolized by 3A4, like digoxin, although digoxin metabolism is complex, or certain statins, simvastatin, lovastatin, or calcium channel blockers, phylidipine, clarithromycin can dangerously increase their levels, leading to toxicity. For example, digitalis toxicity, rhabdomyolysis with statins, excessive hypotension. Many azole antifungals, ketoconazole, itraconazole, protease inhibitors, ritonavir, amiodarone, and even grapefruit juice are potent inhibitors of CYP3A4. SSRIs like fluoxetine can inhibit CYP2D6. Isoniazid acid, anti-TB, inhibits several CYPs.
Grapefruit juice.
Yes, seriously. It's a potent inhibitor of intestinal CYP3A4 and can significantly increase the levels, bioavailability of many common drugs like statins, calcium channel blockers, and benzodiazepines, leading to potential toxicity. A crucial point about inhibition versus induction. Inhibition occurs much faster, often within hours to days as soon as the inhibitor reaches sufficient concentrations, than induction, which requires synthesis of new enzyme protein and can take weeks to reach maximal effect. This makes inhibitors generally more problematic for causing acute toxicity. Some drugs like clarithromycin or verapamil also inhibit P-glycoprotein, PGP, an efflux transporter pump in the gut wall, kidney tubules, and blood-brain barrier, which further contributes to increased absorption and decreased elimination of certain drugs, like digoxin, dabigatran.
Okay, inhibitors raise drug levels, risk toxicity, and act faster. That's critical. Finally, let's briefly touch on pharmacokinetic interactions involving renal excretion, and then we can move to pharmacodynamic interactions where the drugs affect the body's response directly.
Sure. Renal excretion interactions primarily involve interference with those tubular transport processes we discussed earlier, active secretion or reabsorption. We already mentioned urine pH manipulation with ion trapping using sodium bicarbonate for aspirin overdose is a deliberate beneficial DDI that enhances renal excretion. Another mechanism is competition for active tubular transporters. The classic example is probenecid inhibiting the OATs, thereby preventing the renal tubular secretion of penicillin and increasing its half-life. While not used much for that purpose now, it perfectly illustrates the mechanism. Other drugs can compete for the same transporters, for example. Trimethoprim, part of cotrimoxazole, can inhibit the tubular secretion of creatinine via transporters, causing a rise in serum creatinine that doesn't reflect a true change in GFR. NSAIDs can reduce renal blood flow and interfere with the action of diuretics. So interactions can happen at the kidney level too.
Okay, now let's switch to pharmacodynamic PD interactions. These aren't about changing drug levels, EDME, but about how the drug's effects on the body interact, right? At the receptor or system level.
Yep, exactly. Pharmacodynamic interactions occur when one drug modifies the pharmacological effect of another drug without changing its concentration. These can be additive or synergistic effects. This is when two drugs have similar therapeutic effects or similar side effects, and their combined effect is additive, 1 + 1 = 2, or synergistic, 1 + 1 = 3, greater than the sum. For example, combining multiple drugs that cause sedation, like benzodiazepines, opioids, antihistamines, leads to additive CNS depression. Your source gives the example of salbutamol, a beta agonist, and hydrochlorothiazide, a diuretic, both potentially causing hypokalemia. Using them together creates an additive risk of low potassium. Another example, Combining multiple antihypertensives like an ACE inhibitor and elapril and a vasodilator, sildenafil, can lead to additive or synergistic blood pressure lowering. This can be beneficial if hypertension is uncontrolled, but dangerous, causing severe hypotension if blood pressure is already well controlled.
So effects adding up, sometimes dangerously. What else?
Antagonistic or opposing effects. This is where one drug blocks or directly counteracts the pharmacological effect of another, often at the receptor level. Your source gives two nice examples. Direct antagonism. Warfarin works as an anticoagulant by inhibiting vitamin K-dependent clotting factor synthesis. Vitamin K itself, if administered, directly counteracts warfarin's effect by providing the substrate for those factors. This is used clinically to reverse warfarin toxicity, example after rat poisoning. Functional antagonism. Haloperidol is an antipsychotic that blocks dopamine D2 receptors. Levodopa is used for Parkinson's disease to increase dopamine levels. Giving them together creates opposing effects at the dopamine receptor. Haloperidol can worsen Parkinson's symptoms or the extrapyramidal side effects associated with dopamine blockade. Similarly, beta blockers antagonize the effect of beta agonists like salbutamol. Functional antagonism. Understanding these direct physiological interactions is just as important as understanding the pharmacokinetic ones for rational prescribing and patient safety. You need to think about both how drug levels change and how their ultimate effects interact.
We've talked a lot about the causes and mechanisms of kidney disease. Now, let's bring it all together by discussing the complications, prognosis, and the often very challenging management of chronic kidney disease, or CKD. What's the stark reality of CKD progressing to end-stage kidney disease, or ESKD, both globally and particularly in our context here in South Africa?
The reality is profound and honestly often quite disheartening. CKD is highly prevalent worldwide, a true global health issue. And ESKD, requiring dialysis or transplantation, is one of the most expensive non-communicable diseases to manage. For instance, the U.S. spends an astronomical amount, maybe approaching $3 trillion per year now, on renal replacement therapy, RRT.
Wow.
In South Africa, the situation is particularly challenging due to resource constraints. We currently dialyze around 11,000 individuals, but estimates based on our GDP compared to similar countries suggest we probably should be dialyzing closer to 45,000 people to meet the actual need.
That's a huge gap.
A massive gap. It's a huge financial burden, even for private medical aids. Your source mentions Discovery spending R1 billion per year just on hospitalization costs for about 3,000 insured dialysis patients. This financial and resource gap means, tragically, many patients who need RRT simply don't get access to it, particularly in the public sector.
So as kidney function inexorably declines towards ESKD, what crucial functions are actually lost? And why is this progression often so insidious and silent, making early detection such a challenge?
As kidney function declines, patients progressively lose crucial excretory functions. The ability to efficiently remove metabolic waste products like urea and creatinine, excess acid load, phosphate, sulfate, and other toxins. They also lose salt and water homeostasis, leading to problems with fluid balance, volume overload edema, and blood pressure control, hypertension. And critically, they lose vital hormonal functions. The kidney is an endocrine organ. It stops activating vitamin D effectively, leading to bone disease, and it stops producing enough erythropoietin EPO, leading to anemia.
Right, the endocrine parts too. Why so silent?
The silent progression is truly problematic because the kidneys have tremendous reserve capacity. The GFR can drop from a normal level over 90 or 100 millimin down to maybe 30, 20, or even as low as 10 millimin before any overt symptoms of uremia appear. It's like your body's quietly dismantling its filtration system brick by brick without a warning light coming on until the whole wall is about to collapse. This highlights the critical importance of screening and monitoring at-risk patients, those with hypertension, diabetes, HIV, or a strong family history via simple blood tests, UNE for creatinine GFR, and urine tests, dipstick for protein blood, maybe urine ACR, because by the time patients feel sick from kidney failure, significant, often irreversible, damage has already occurred.
Yeah, when symptoms do finally appear, they're often non-specific, right? Complicating early diagnosis even further. What are some of those vague, non-specific symptoms of uremia that we should be alert for, even though they could point to many other things?
Exactly. Patients might report things like persistent nausea, maybe frequent hiccuping, a general lassitude, just a profound feeling of weariness and lack of energy, anorexia or loss of appetite, maybe a metallic taste in the mouth, difficulty concentrating, itching, pruritus, or symptoms of anemia like fatigue and shortness of breath. These are all very general symptoms that can easily be attributed to aging, stress, poor sleep, or other conditions. This often delays diagnosis until the disease is quite advanced. Furthermore, CKD impacts nearly every organ system: cardiovascular, the biggest killer in CKD patients, metabolic bone disease, pulmonary, neurological, hematological, leading to very high morbidity and mortality rates. Labs now thankfully provide the estimated GFR, eGFR, and CKD stage directly, stage 1 to 5, which helps track progression. And it's important to realize that early complications, particularly cardiovascular risks and bone mineral metabolism issues, often start to appear as early as stage 3 CKD, when GFR is between 30 and 59 milliman. You don't have to wait until stage 5 for problems to start.
This leads us to the challenging reality you mentioned earlier, the waiting lists for dialysis in many public sectors. It sounds like a truly heartbreaking situation for patients and clinicians alike.
Yes, it is. It's one of the toughest ethical and practical challenges in nephrology in resource-limited settings. Unfortunately, in many government hospitals in South Africa and elsewhere, there are strict eligibility criteria and effectively waiting lists for chronic dialysis due to limited machines, funding, and staff. This means patients often crash land at CKD stage 5, presenting very late, often in extremis, with severe uremic symptoms requiring emergency dialysis initiation.
And if they don't meet the criteria or there are no slots.
For those not accepted for renal replacement therapy due to these severe limitations, palliative care often becomes the only realistic option, focusing on symptom management, quality of life, and supporting the patient and family through a difficult time. This stark reality underscores the critical, life-saving need for organ donation. Despite South Africa having high rates of premature death from trauma, our organ donation rates remain tragically low compared to the need. Transplant truly is life-saving. It's often considered the only treatment that can really give patients their life back, offering better survival and quality of life than long-term dialysis. It's unlike managing other chronic diseases where you mainly control symptoms. Transplant replaces the failed organ's function.
So what are the absolute key management strategies for CKD, aiming to prevent or slow down that progression? It sounds like we need to start by identifying and correcting anything that might be reversible, any acute hits on chronic disease.
Absolutely. The initial management and ongoing management really focuses intensely on identifying and correcting any potentially reversible factors that could be accelerating the decline in kidney function. This includes diligently assessing volume status. Is the patient dehydrated, leading to a prerenal component of AKI superimposed on their CKD? Or are they fluid overloaded, which strains the heart and worsens hypertension? Your source mentions the common scenario of patients presenting anuric with a systolic BP of 60, a clear sign of severe hypovolemia needing urgent fluid resuscitation. Identifying and removing nephrotoxic drugs or toxins. This means stopping or avoiding aminoglycosides and NSAIDs, and reminding patients that even over-the-counter ibuprofen or naproxen and prescription COX2 inhibitors like Celebrex or Arcoxia are not kidney-safe long-term, especially with CKD. Avoiding intravenous contrast agents whenever possible, and being cautious with newer drugs like SGLT2 inhibitors, which can cause an initial dip in GFR.
Right, the drug review is critical.
Absolutely. And avoiding that dreaded triple whammy, the combination of an ACE inhibitor, or ARB, an NSAID, and a diuretic. This combination can severely impair renal autoregulation and GFR, sometimes causing what nephrologists vividly call a medical nephrectomy. Always check renal function, U&E, about 1 to 2 weeks after starting potentially problematic new medications to catch any acute decline early. Treating other reversible factors like uncontrolled hypertension, active sepsis, episodes of acute tubular necrosis, ATN, or specific underlying kidney diseases like treatable forms of chronic glomerulonephritis if diagnosed.
Okay, once those reversible factors are addressed as much as possible, the focus shifts to actively slowing the inevitable progression of CKD and preserving whatever kidney function remains for as long as possible. What are our primary strategies here?
This is the core of long-term CKD management. Key strategies include aggressive blood pressure control. This is probably paramount. While the general target is often cited as less than 440/90 millimolar Hg for patients with significant proteinuria, albuminuria, or diabetes, the target is usually stricter, often aiming for less than 380/80 millimolar Hg. ACE inhibitors, ACEIs, and angiotensin receptor blockers, ARBs, are generally first-line agents, especially in proteinuric patients, as they have specific evidence for slowing CKD progression beyond just lowering BP by reducing intraglomerular pressure.
You need to monitor when starting ACE-ARBs, right?
Yes, absolutely. Always monitor potassium and creatinine, UNEs, within 1 to 2 weeks of starting or increasing the dose of an ACEI or ARB. A small rise in creatinine up to 20–30% might be acceptable, but a larger rise could indicate underlying renovascular disease requiring investigation. If BP remains uncontrolled on maximally tolerated doses, you add other agents like calcium channel blockers, CCBs, diuretics, thiazides in early CKD loops in later stages, beta blockers, alpha blockers, often requiring multiple agents. Referral to a nephrologist or hypertension specialist is warranted if BP is resistant on 3 or more drugs. And addressing patient adherence due to side effects or complex regimens is critical. You have to actively counsel them and troubleshoot. Reducing proteinuria albuminuria. Directly targeting protein leak is also vital, as proteinuria itself is toxic to the tubules and accelerates progression. ACIs and ARBs are the primary agents for this. Non-dihydropyridine CCBs like verapamil, diltiazem might have some additive antiproteinuric effect. Newer agents like SGLT2 inhibitors and finerenone also significantly reduce albuminuria and slow progression in diabetic kidney disease. Tight glucose control. For diabetic patients achieving optimal glycemic control, typically aiming for an HbA1c below 7%, or individualized target, is crucial, especially early on, to prevent or slow the progression of diabetic nephropathy. However, HbA1c can become less reliable in advanced CKD due to altered red blood cell lifespan. Relying on fingerstick glucose monitoring or continuous glucose monitoring CGM logs might be more accurate then. Avoiding hypoglycemia is also critical. Dietary management. This is a cornerstone which we'll discuss more, but generally involves appropriate protein restriction, controversial but often advised in later stages if nutrition is adequate. Sodium restriction, potentially potassium, and phosphate restriction depending on labs. Avoiding nephrotoxins. Constant vigilance is needed to avoid exposure to potentially kidney-damaging drugs or substances. Maintaining adequate hydration, especially during intercurrent illnesses. Early recognition and treatment of infections. Maintaining good overall nutrition to prevent wasting. Managing complications. Treating anemia with EPO and iron, managing metabolic bone disease, CKD-MBD, with phosphate binders and vitamin D analogs, correcting metabolic acidosis with bicarbonate.
Let's delve deeper into dietary management now for CKD patients. It seems to be an incredibly integral, but also notoriously complex and difficult component of treatment. What are the general principles, and how does the approach become more stringent as CKD progresses through the stages?
Nutrition is absolutely integral to CKD treatment and can significantly impact outcomes, slowing progression and managing complications. It really demands a multidisciplinary approach, with a registered dietitian specializing in renal nutrition being a crucial member of the team. Guidelines like KDI Go, kidney disease, improving global outcomes, provide evidence-based recommendations. The approach definitely changes based on the CKD stage, often using the CGA criteria, cause, GFR category, albuminuria category.
Okay, how does it change?
For earlier stages, say G1 to G3B, GFR down to 30, the focus is often aggressive nutritional treatment of the underlying causes of CKD, like managing hypertension, diabetes, and obesity through diet to slow progression. The diet might involve moderate sodium restriction and focus on healthy eating patterns like DAH or Mediterranean style, but is generally less restrictive otherwise. However, as patients progress to stages G4, GFR 15-29, and G5, GFR 15 or dialysis, a much more stringent and highly individualized diet is necessary, often involving careful restrictions of proteins, sodium, potassium, and phosphorus, plus fluid restrictions tailored to the individual's labs, nutritional status, and treatment modality, for example, HD versus PD versus conservative.
What does that comprehensive nutritional assessment entail? Your source mentions the ABCD acronym. How do we get a full picture of the patient's nutritional status beyond just asking what they eat?
Right, the ABCD framework ensures a holistic view because malnutrition or protein energy wasting, PEW, is very common and a major predictor of poor outcomes in CKD. Anthropometric assessment. This includes tracking weight history. Unintentional weight loss is a red flag. Calculating BMI, interestingly, in CKD. A slightly higher BMI, maybe around 25, 28 km/2, is often associated with better prognosis. The obesity paradox likely reflecting better muscle mass and reserves, highlighting the danger of malnutrition. Measuring waist-to-hip ratio for central obesity, and mid-upper arm circumference, MUAC, or skin fold thickness to gauge muscle and fat stores. Bioimpedance analysis, BIA, can provide trends in body composition, fluid, fat, muscle mass over time. And we always need to consider the patient's dry weight adjusted for any edema or fluid overload.
Okay, body measurements. What's B?
Biochemical assessment. Monitoring key lab parameters related to nutrition and CKD complications, things like albumin, marker of nutritional status and inflammation, prealbumin, electrolytes, sodium, potassium, phosphate, calcium, bicarbonate for acidosis, markers of bone health, PTH, vitamin D, lipid profile, and indicators of anemia, hemoglobin, iron studies.
Great.
Clinical assessment, looking for physical signs and symptoms of malnutrition or uremia, muscle wasting, loss of subcutaneous fat, weakness, fatigue, edema, shortness of breath, poor appetite, nausea, vomiting, metallic taste in the mouth, uremic fetor, a distinctive fishy breath odor, as well as assessing blood pressure control. Dietary assessment. This is where the dietitian really shines. It involves a deep dive into the patient's actual food habits, using tools like food frequency questionnaires, 24-hour recalls, or food diaries. Understanding their preferences, usual intake patterns, tolerance to foods, any feeding issues like difficulty chewing or swallowing, and crucially, their socioeconomic status, cultural background, food access, and geographical challenges that might impact their ability to follow dietary recommendations. You can't just hand someone a list. You need to understand their reality.
Can you give us a concrete example of how this individualized approach applies to a patient, perhaps drawing from the patient X case study in your sources?
Yes, the source provides an excellent example with patient X, a 74-year-old male whose CKD progressed from G3B to G4 due to underlying hypertension. He was a former boxer and still exercised, meaning he likely had higher muscle mass than average for his age. His detailed nutritional assessment showed his total energy intake was actually inadequate, but his intake of protein, phosphorus, potassium, and sodium were all excessive relative to his needs at CKD stage G4. His BMI of 32.5 kg/U2 classified him as mildly obese, and his high MUAC reflected his history and current activity. So the tailored nutritional aim for him wasn't just a generic low-protein, low-salt diet. It was specifically to restrict salt, fluids, and moderate his protein intake within his overall energy requirements, which might actually need to be increased slightly to prevent muscle loss, primarily to alleviate his uremic symptoms and perhaps facilitate some gradual healthy weight loss given his BMI. This highly individualized plan, considering his history, activity level, and specific excess deficits, is far more effective than just giving him a standard CKD diet sheet.
Let's break down the specific dietary considerations in more detail, starting with protein. This seems controversial and complex. How do we manage protein intake, and why is that so critical yet tricky for CKD patients?
Protein management is indeed critical and often debated. The absolute priority is to maintain a neutral or positive nitrogen balance to prevent protein energy wasting, PEW, which is strongly linked to increased morbidity and mortality, while simultaneously trying not to worsen renal function by overloading the remaining nephrons. The hyperfiltration hypothesis suggests high protein intake can accelerate damage. It's a very fine balance.
So how much protein?
The recommended intake varies significantly by CKD stage and treatment modality. For hemodialysis, HD patients, intake needs to be higher, typically around 1.2 kilograms of ideal body weight per day, because they lose about 5 to 8 grams of amino acids protein during each dialysis session. For peritoneal dialysis, PD patients, intake needs to be even slightly higher, maybe 1.2, 1.3 kilocalories a day, because they lose significantly more protein, up to 30 dd sometimes, through the peritoneal fluid. For patients not on dialysis, managed conservatively, usually stage 4 to 5, the recommendation is generally lower, often around 0.6, 0.8 kilocalories a day, to try and reduce the burden on the kidneys and minimize uremic toxin generation. However, this must be done very carefully with close monitoring by a dietitian to ensure adequate energy intake and prevent malnutrition. Some studies suggest very low protein diets, 0.3, 0.4 kilograms, supplemented with essential amino acids or keto analogs, but these are hard to follow.
Does the quality of protein matter?
Yes, quality matters significantly. Traditionally, emphasis was placed on ensuring sufficient high biological value, HBV protein, from animal sources like meat, poultry, fish, eggs, dairy, which provides all essential amino acids. Often the recommendation was for at least 50% of protein intake to be HBV. However, newer research suggests potential benefits from incorporating more plant-based proteins, legumes, tofu, nuts, seeds. These may generate fewer uremic toxins, improve the gut microbiome, reducing inflammation, and help with managing phosphorus and metabolic acidosis. But ensuring adequate intake of all essential amino acids can be more challenging with purely plant-based diets in this population. The key is probably a balanced approach, individualized and avoiding highly processed foods, regardless of the protein source, because those are often loaded with sodium and phosphate additives.
Okay, and what about energy from fats and carbs?
Yeah.
And the constant struggles with sodium and potassium?
They are indeed constant struggles. Energy intake must be adequate, typically 25-35 kilocalories a day depending on age and activity level, to spare protein for tissue repair and synthesis, and to maintain a healthy weight. Patients need enough calories from fats and carbohydrates to prevent their bodies from breaking down precious muscle mass for energy. General guidelines often follow heart-healthy principles like the TLC diet, therapeutic lifestyle changes, suggesting maybe 25–30% of energy from fats with 7% saturated fat, low trans fats, and 50–60% from complex carbohydrates. For diabetics, good glycemic control is crucial not just for blood sugar, but also to reduce albuminuria and slow CKD progression. Remember, malnutrition itself significantly increases morbidity and mortality in CKD.
Sodium, the salt battle.
The sodium battle is huge. Excess sodium intake is a primary driver of thirst, fluid retention, edema, hypertension, worsening heart failure, and may even directly accelerate CKD progression and contribute to metabolic acidosis. A shocking amount, maybe 75–90% of sodium in Western diets comes hidden in processed, packaged, and restaurant foods, not just from the salt shaker. CKD patients are often very salt sensitive, meaning their blood pressure responds dramatically to changes in salt intake. The usual recommendation is to limit sodium intake to less than 2,300 milligramma, which is about 100 millimole or roughly 1 teaspoon of salt, sometimes even lower, 1,500 milligramma if possible. Fluid restriction often goes hand in hand with sodium restriction, especially for patients on dialysis or those with significant edema or heart failure. The goal is often to limit interdialytic weight gain, IDWG on HD, to less than 4 or 5% of dry weight, maybe 2 kilograms between sessions, as large fluid gains are linked to higher mortality. Providing clear, practical handouts and education on reading food labels and making low-sodium choices is vital.
And potassium. When do we restrict that?
Potassium management depends heavily on the CKD stage, urine output, and importantly, the patient's serum potassium levels and medications. Dialysis removes potassium, but restriction is often needed between sessions to prevent dangerous hyperkalemia, especially in patients who are anuric, no urine output, or oliguric, low urine output, typically in stage 5 CKD, or if they have persistent hyperkalemia or are on medications that retain potassium, like ACI-SARBs, spironolactone, and NSAIDs. However, it's important not to over-restrict potassium unnecessarily in earlier CKD stages, like 3–4, if the levels are normal. Why? Because potassium can actually act as a vasodilator, potentially helping with blood pressure control, and adequate intake helps manage metabolic acidosis. Plus, many healthy foods rich in potassium, fruits, vegetables, legumes, also offer other benefits. Plant-based foods might also be better tolerated as they promote insulin response, shifting K intracellularly, and increase stool output, another route for K excretion. Certain cooking methods like boiling vegetables in large amounts of water and discarding the water, leaching, can remove maybe 20–50% of the potassium. Newer potassium-binding drugs are also available now for persistent hyperkalemia. So again, it's individualized based on labs.
Finally, let's talk about phosphorus and other minerals, vitamins in the CKD diet. Phosphorus in particular sounds like a major villain in CKD bone disease.
Phosphorus retention is indeed pivotal, a central player in CKD mineral and bone disorder, CKD-MBD. Healthy kidneys are incredibly efficient at filtering and excreting excess dietary phosphorus. They filter a massive amount, 3,700–6,100 milligrade, reabsorb most of it, 75–85%, and precisely excrete the net amount needed to maintain balance, usually 600–1,500 milligrade, matching dietary intake. In CKD, as GFR falls, the kidneys lose this ability to excrete phosphorus effectively. This leads to rising phosphate levels, hyperphosphatemia, usually becoming apparent when GFR drops below about 30–40 mmol/min.
And why is high phosphorus so bad?
Hyperphosphatemia directly stimulates the parathyroid glands to release more parathyroid hormone, PTH, leading to secondary hyperparathyroidism. It also inhibits the activation of vitamin D in the kidney. High phosphate levels, along with high PTH and disordered vitamin D, contribute significantly to renal osteodystrophy, abnormal bone turnover and mineralization, increased fracture risk, and perhaps most importantly, extensive vascular calcification. Calcium and phosphate depositing in blood vessel walls, leading to arterial stiffness, hypertension, heart disease, and significantly increased cardiovascular mortality. Therefore, minimizing the dietary phosphorus load is absolutely crucial.
How do we do that? Binders.
Yes, management involves a three-pronged approach. 1. Dietary phosphorus restriction, aiming for maybe 800 to 500 millimole of Fastglide, or targeting a phosphorus to protein ratio, for example, 12–14 milligram phosphorus per gram of protein. This requires avoiding foods very high in phosphorus, especially processed foods with phosphate additives, which are highly bioavailable, colas, dairy products, nuts, seeds, and whole grains. It's tricky because many high-protein foods are also high in phosphorus. 2. Intestinal phosphate binders. These medications are taken with meals to bind dietary phosphorus in the gut and prevent its absorption. Options include calcium-based binders like calcium carbonate or acetate preferred in pediatrics but risk hypercalcemia in adults, and non-calcium-based binders like sevelamer or lanthanum, often preferred in adults to limit calcium load. Aluminum-based binders are effective but avoided long-term due to toxicity. Total calcium intake, including that from binders, should ideally be limited, maybe 2 every day. Educating patients on when and how to take their binders consistently with meals is critical for effectiveness. 3. Adequate dialysis. For dialysis patients, ensuring sufficient dialysis clearance helps remove phosphorus. 4. Managing vitamin D. Using active vitamin D analogs like calcitriol or precursors carefully to suppress PTH without worsening hypercalcemia or hyperphosphatemia. 4. Managing vitamin D. It's a constant balancing act. Studies show that even a modest increase in serum phosphorus, 0.33 millimol, is associated with an 18% increase in mortality risk. But over-restriction, especially of protein, to limit phosphorus, risks protein energy wasting, requires very careful management and monitoring.
What about other minerals and vitamins? Any key points there?
Yes, briefly. Iron. Supplementation is often needed, especially if patients are receiving erythropoiesis-stimulating agents, ESAs, like EPO for anemia. Oral iron absorption can be poor in CKD. Intravenous iron is often required. Advise patients not to take oral iron simultaneously with phosphate binders or high doses of vitamin C, as this can affect absorption. Vitamin C should generally be limited, maybe to 100 milligrams a day around the RDI. Very high doses, 500 milligrams a day, may increase oxalate production and risk kidney stone formation or deposition in tissues. In AKI, doses 200 milligrams a day have been linked to vascular injury. Water-soluble vitamins. Vitamins like folate, niacin, riboflavin, B6, and B12 can be lost during dialysis, and requirements might be increased due to uremia or poor intake. Renal multivitamin supplements containing these are often prescribed for dialysis patients. Fat-soluble vitamins, A, D, E, K, generally not routinely supplemented except for vitamin D in specific forms like active calcitriol or precursors to manage CKD MBD. Vitamin A can accumulate to toxic levels in CKD as it's renally cleared, so supplements containing high doses should be avoided. Vitamin E might be considered sometimes for specific issues like red blood cell fragility, but isn't routine. Vitamin K status might be relevant for bone health and vascular calcification, but routine supplementation isn't standard practice.
Okay, this all sounds incredibly complex to manage, requiring a huge amount of buy-in and effort from the patient. How do we actually help patients implement and comply with these highly restrictive and personalized dietary plans long-term?
You've hit on the biggest challenge in clinical practice. It's one thing to know the recommendations, quite another to live them day in, day out. Individualized meal plans, like providing cycle menus with choices the patient actually likes and can afford, are vital to give them options and variety. But these plans are meaningless without consistent ongoing patient education and counseling, ideally from a renal